teacher and mentor. This is our alma mater. He studied here in the 1959 batch. Many of his classmates are here. Professor Krishnan sir is here. So, we are all guided by his wisdom and his hard work. He was the most hardworking of all our teachers. Here you can see it is very, very difficult for anybody to do anything in a government setup. So he was the professor of radiotherapy in Trivandrum Medical College. Even at that time, he managed to start a cancer research division, and also he was successful in installing the first remote control afterloading system, a big thing in radiation oncology, for the first time in India, ahead of Tata Memorial, All India Institute, TGI, and so many other institutions. So it speaks volumes about his organizational ability. And here you can see the foundation stone of the Regional Cancer Center was laid by Sri K. Karunakaran, and the inauguration was by E.K. Nair. On both these occasions, I was there in the Medical College and RCC. So this also is giving a testimonial to his abilities to manage people of two opposition groups alike. And before I go further, I just want the Alumni Association to try our best in naming the Regional Cancer Center after him. It should be Professor M. Krishnan Nair Regional Cancer Center, because it is only his single-handed, hard-working efforts that made this institution into a reality. We know he belonged to the 1959 batch. At that time, he did MD radiology. It was a combined specialty then. There was no medical oncology at that time. Later, he did FRCR, clinical oncology at Christie Hospital, Manchester. And then, as Veladambala sir rightly said, Professor Thangavelu sir, he was the principal and he had an understanding between the college and Manchester. And that way, he managed to send 3 of our doctors to Christie Hospital, Manchester. And the first one was Professor Krishnan Nair, second one was Professor T.K. Padmanabhan, and the third one was Dr. C.D. Joseph, who was in Amala Cancer Institute later. So, you all may be remembering the days of Ward 10, 11, 12, and 13, where a lot of cancer patients used to get admitted. And during examination time, we used to go and see patients. But at that time, we undergraduates were posted in oncology, and we got some very good exposure, and we were taught well. And it was only because of the stimulus which he gave that we could further proceed to do post-graduation in the specialty. He was successful in convincing P.N. Wahi committee, and that is how the Regional Cancer Center came to Trivandrum. First, it was Cancer Institute when we were students in 1974. Then it became Institute of Oncological Sciences. Then finally, the Regional Cancer Center. So he was the president, first ever president of Association of Radiation Oncologists of India from Kerala. And he was instrumental in the setting up of a hospital-based cancer registry project at Medical College Hospital, the National Cancer Registry Project, Karunakappally and Trivandrum, the population-based cancer registry, Cancer Research Wing and Epidemiology for the first time. National Cancer Control Program was drafted. He was one of the leading persons to draft it. What is peculiar about him is that he instituted so many fellowships through NCA, Christie, MAST and British Council and so many other international and national agencies to train his subordinates. And that is how he brought RCC to the present level and commissioned many oncology and radiotherapy equipments in the Medical College Trivandrum and later at RCC. He has more than 250 international publications, and he was instrumental in the starting up of the pain and palliative care in Kerala. I still remember the day when he held a meeting in Regional Cancer Center at a time when Gilly Byrne and others from Oxford came over. The first pediatric oncology department was in India, was started in Trivandrum Medical College. Now they are doing DM in pediatric oncology. The first medical oncology department in Kerala was also started by him. He appointed Dr. V.P. Gangadhar. So this is the family photograph. You can see the lady behind the successful man, Valsala Madam, and then the daughter, granddaughter, son-in-law, and a son. We had the fortune to celebrate his birthday once during our national conference. It is 23rd November. His star was Revati, I still remember. And then here you can see he is cutting the cake. And the success of RCC is because he had a great support from Professor T.K. Padmanabhan, who belonged to the 1961 batch. Here you can see him giving the cake. So they complemented each other, they never fought each other, and it is only because of that the Trivandrum Medical College was the best for cancer care in the whole of India at that time. So he was always there in all academic activities. You can see when we conducted the 2009 Oncology 2009, 2012, all these situations, he was very active and he used to guide and give a lot of advice and support. Here you can see this is his classmate, very favorite classmate, Dr. C.D. Joseph, who is no more now. This is a moment with Dr. Rao from Christie Hospital, Manchester. This is with Dr. Advani, with the Srimati teacher. And this is the first office bearers of the Alumni Association. The alumni was started. We could persuade him to be the first president. And you can see Dr. Jayaprakash Madhavan here, the chairperson. He was the first vice president, myself the secretary, and most of us are from radiation oncology. So I just bow before all my great teachers in this alma mater, but specifically I would like to mention Professor Matthew Roy, who was always inspiring and guiding, and who struggled a lot, struggled maximum to train his students. I could honor Professor T.K. Padmanabhan, moment with him in Sriperumbudur. This is the Professor of Medical Oncology, Dr. Balarmin, the first qualified medical oncologist in India. So he was our mentor in Madras Medical College. This is a moment with PGR sir, who helped a lot in cancer care. And also you can see my other mentor, Velayutham Pilla sir, who could ensure that I am getting placement for a WHO fellowship in USA. I still remember. This is Professor Vijayalakshmi who taught me a lot. Professor Krishnan Nair also could see that a lot of his students are adorning big positions throughout the world in very many top institutions. I am not naming. So one of the misconceptions, now coming to the topic, I will be rushing through the slides because of paucity of time. But anyway, I will be talking based on my own cases. They are not hypothetical cases. They are not anecdotal also. So one of the misconceptions today is that metastatic cancer means palliative care. So this has to be corrected. Now there is no basic exposure in oncology for undergraduate students now, and that has resulted in the concept that metastatic cancer means only palliative care is possible. The truth is that oncology cannot be practiced without knowing palliative care, and palliative care cannot be practiced without knowing oncology. Cancer is conquerable rather than curable. We have a lot of new drugs, targeted therapy agents, systemic therapy, apart from conventional the chemotherapeutic agents, immunotherapy, etc. Local treatments also, lot of new developments, techniques in precision radiation oncology, RFA, cryotherapy, robotic surgery, TACE, all these have added to the survival of cancer patients. I am not going into the epidemiology, but most of the treatments are based on the different hallmarks of cancer. This also I am not going to elaborate. So, precision oncology. Today morning, Dr. Prakash was talking about precision oncology and molecular guided therapeutic options, liquid biopsy, advances in surgery, precision radiation oncology. Artificial intelligence is something which has come in a big way because it has started challenging the guidelines. Even the NCCN guidelines are challenged by artificial intelligence because in situations where there are no options, artificial intelligence is able to suggest so many options, and then in very many situations it is producing wonderful results. Now the molecular testing has gone up from IHC to whole exome sequencing, whole genome sequencing, etc. I am not going into the details. Here you can see the treatment options have increased over the last few decades. And also there is increased workload as the complexity of diagnosis, evaluation and treatment has also increased. Lot of difference between conventional chemotherapy, targeted therapy and immunotherapy. Today morning Dr. Prakash was telling a bit about that. I don't want to go into that. Breast cancer is very important because it is the number one malignancy affecting the female. Every 6 minutes, one patient is dying of breast cancer, and 1 out of 8 women are likely to develop breast cancer. And if detected and treated, it is curable. So, unlike what we were taught during our student days, it is not a single disease. There are so many subtypes, and there are a lot of molecular subtypes. And this is the era of precision oncology, and we have to give a personalized treatment by evaluating these cases in the best possible way. So this is actually inherited breast cancer predisposition in Asians. I am not going into the details. So generally what we do is we will be first doing an immunohistochemistry, then classifying them to hormone receptor, triple negative, HER2 positive, etc. Basically, of course, we will be going in depth by doing some more tests. I am not going into the details. But this HER2 positive disease, lot of advancements have happened from the discovery of trastuzumab and approval in 1998 to the today, when we have a lot of antibody drug conjugates like trastuzumab, emtansine, trastuzumab, deruxtecan, etc. Essentially, what happens is the cells are rich in a lot of receptors, the HER2 receptors, and the HER2 receptors are dealt with by blocking them with monoclonal antibodies, thereby preventing the multiplication. Here you can see a case of carcinoma breast which progressed after surgery, radiation and conventional chemotherapy, getting good control with targeted therapy with tyrosine kinase inhibitor, lapatinib. Similarly, during our student days, when there is an ulcer like this, very often our surgery teachers used to say that it has to be excised. But now you can see how effectively trastuzumab could control the ulcer. So let me tell about my first case. This patient was actually first seen in our tertiary cancer center in this campus. He had conventional chemotherapy and she developed jaundice, and then she was sent home saying that her survival is limited. But she is a beneficiary of the ESI scheme. She came over to the private hospital where I was working, and we treated her, and she survived 7 years. He received 168 injections of trastuzumab and trastuzumab, emtansine, etc. And finally, we lost her only because of COVID pneumonitis. Here you can see her cutting a cake. And this is another patient, a case of carcinoma male breast, which was diagnosed in 1992. Neoadjuvant chemotherapy followed by surgery was done. Then patient was on tamoxifen for some time. In 2008, he developed a pleural effusion. Again, we tapped the effusion, gave conventional chemotherapy, and again she was put on tamoxifen. But in 2014, he developed a lung metastasis. We did the biopsy and found that the tumor has become HER2 positive and estrogen receptor positive. Thereafter, he received specific treatments using many drugs. Of course, finance was a problem. So he received tyrosine kinase inhibitors, then trastuzumab, emtansine, etc. What you can see is that in spite of advanced disease, he could survive. Here also, you can see the level of the CEA increasing and coming down as it responds to treatment. So the patient lived 29 years. So it is very important for us to do periodic biopsies, because there will be a change in the molecular subtype, and accordingly we will have to modify the treatment. This is another patient, a lady who had a HER2 positive disease. Actually, they are supposed to have 1 year of adjuvant trastuzumab, but she did not take that. And you can see that there is a big liver lesion here. Of course, with the trastuzumab, it responded very well, and it almost totally disappeared. And when we did the endoluminal ultrasound guided biopsy, there was hardly anything. But again, she discontinued the treatment, and because of that, in spite of the good initial response, she developed progressive disease, and today she is on another antibody drug conjugate, that is trastuzumab deruxtecan. So these are antibody drug conjugates producing wonderful improvement in survival. I'm not going into the details. And here also the progression-free survival, overall survival is also improved. Here again another HER2 positive breast cancer. The patient had a chemotherapy, surgery, then developed unfortunately metastasis, and then you can see the metastasis here, and the patient had received stereotactic radiosurgery at Ashram Medicity, in spite of which there was disease. Then she received further treatment with tucatinib, one of the new tyrosine kinase inhibitors, and it has produced very good results. But it is very difficult for the patient to afford such a costly drug. You can see the lesion after stereotactic radiosurgery. There are neurosurgeons here. But here you can also see how beautifully it has responded to trastuzumab deruxtecan, which is a very costly antibody drug conjugate. But ESI patients can definitely have this. Similarly, estrogen receptor positive disease also, it is possible for us to get very good control of the disease. So here is a patient who had metastatic cancer, but we could control the disease with the hormonal manipulation. Then of course it changed to HER2 positive molecular subtype. Then we managed it with anti-HR2 therapy. Altogether the patient survived more than 5 years. These are all the various endocrine therapy options. I am not going into the details. Similarly, the PARP inhibitors are another class of drugs which has come into use more frequently in our country. It prevents the DNA repair, so it is also capable of controlling the disease better. Similar to the chemotherapy, the radiotherapy also has been able to produce wonderful results. Here you can see a patient who was offered less than 6 months survival. We gave radiation treatment. This was the big lesion, and today the patient is still alive after more than 10 years. This is actually the relative of a famous columnist in our Indian Express. This patient also had a brain metastasis, in spite of which she survived more than 13 years thanks to radiation treatment with the cobalt unit.
May I intervene, Madhu? We have 2 more minutes. I know all good things will have to come to an end.
I am allotted 30 minutes, sir. 30 minutes. 30 minutes ആയിട്ടില്ല. Don't crush this. I was anticipating. If it is an oration, there has to be minimum 30 minutes. Now, I will rush through.
Vinamar, how much time you can give? Tell him. How much?
No, 2 more minutes. I had told in the beginning itself that there should be 30 minutes. No, 30 minutes. 30 minutes is the oration time.
See, Madhu, the oration, total minutes is already 5 minutes. Yes.
No, I don't want to.
Okay.
I don't want to
yes.
make any controversy.
Okay. So how much? Just to tell me, how much time you want?
You should not have made this controversy. But anyway, this is a patient who was demanding palliative care when she presented with the pleural effusion, and she was reluctant, reluctant to get investigated. But we gave treatment empirically, and she responded and survived for many years. Here is a patient, another lung cancer patient who had a good response to anaplastic lymphoma kinase inhibitor. You can see the wonderful response of the brain metastasis. He is a radio jockey. He is still alive more than 5 years. This is yet another patient who also had ALK positive lung cancer. Again, responded beautifully to treatment. You can see big lesions like this can disappear with targeted therapy like this. Here is a patient who had immunotherapy for squamous cell carcinoma lung. The patient survived more than 5 years and is still going strong. But anyway, somebody was talking about the tumor agnostic therapy. I just wanted to show you this because a patient with lung cancer was found to be red fusion positive following liquid biopsy. And then patient received selpercatinib, another drug which is rarely used, very costly medicine. Today, after 5 or 6 years, she is hale and healthy. But at that time, we can see that the CEA level has come down from very high values to normal levels. Molecular tumor board is the key. And here you can see liquid biopsy done for one of our classmates who has survived more than 25 years after the diagnosis of ovarian cancer. In her case also, it is red fusion positive. That means she is also a candidate for treatment with selpercatinib. But the problem is the cost of the medicine. That is an example of agnostic therapy. Lung cancer and ovarian cancer getting treated identically. This is liquid biopsy. Again, you can see how liquid biopsy could be made use of. Ovarian cancer with brain metastasis getting good control of the disease. And the sequencing of therapy, I am not going into the details because of positive time. Anyway, one of the things which has happened in management of renal cell carcinomas is the emergence of targeted therapy and immunotherapy. He is actually brother of my local guardian, professor in Trivandrum Medical College. The patient survived more than 5 years with pasopanib, but of course he could not afford immunotherapy. But this is a patient who had a stage 4 CA colon. Patient survived more than 5 years. Why? What is the importance of that? The importance is that he could celebrate the wedding of the daughter and he could enjoy the grandson. So these are all possible. These are all possible. Even glioblastoma patients, they also can celebrate their survival. If this patient was doomed to die of disease in a short time, but the patient definitely is doing well and going strong. So the patients, in spite of their advanced disease, are very often able to get good control of the disease. Only thing is that we have to be very careful. We should not brand them for simply palliative care, which is happening very often, especially with regard to poor patients, Harijans and others in our country. The cost of the medicine is a problem. The problems are distance to travel, lack of decentralization, crowding of patients, innovator biosimilar generics, oligometastasis, etc. So the lack of awareness, first of all, the undergraduate students have to be properly trained. Then the early option of palliative care should not be permitted. Lack of awareness among doctors by education, this has to be done. The conclusion is that metastatic cancers are controllable and prolonged good quality survival is possible. Newer molecular profiling, targeted therapy have emerged. Timing of various therapies should be optimal. There should not be any disparities in care among different class of patients. The philosophy of treating physicians and the attitude of the family is very, very important. But I would like to urge our alumni association to persuade the politicians and administrators to see that the Regional Cancer Center is named after Professor M. Krishnan Nair. With this few words, thank you all for this.